Well, thank you. And thank you, Dominic, for inviting me and for your hard work and persistence and creativity and determination in this field to see it advance on this side of the Atlantic, and also always being so open to collaboration with me in Chicago. Thank you very much. So I was asked to talk about 2 diseases in 25 minutes. So we're going to have to be a little brief and concise. I'm sorry about that, but it's the only way I can put it in. And the first one was Crohn's disease. And of course, initially when we did autologous transplants for Crohn's, we were choosing people here who had failed a TNF inhibitor, and they were really looking at surgery. And so instead, we would do this autologous transplant instead of surgery. And others, we did the first Crohn's in the world, and it was a cyclophosphamide ATG regimen, and it was very complementary because success has many fathers and failure is an orphan. So other centers started doing it. Here they are. And of course, the most recent randomized trial at the bottom here, which is the AHSCT trial. Unfortunately, that failed the primary endpoint, which was a very strict, rigid endpoint that nobody has ever achieved with any drug. It did succeed in secondary endpoints. Also not listed on here is São Paulo, Dr. Ruiz, and he's actually now done the most in the world. I think he's up to about 60 patients with Crohn's disease and no mortality, and I think very similar results to what everybody else has had. But currently, that's the largest single center experience. So autologous transplant, was it a failure or a success? And that depends on your definition and how you look at it. All the drugs, the standard definition for success is a Crohn's disease activity index, this CDAI of less than 150, while staying on that drug or any other drug. You could be on steroids, you could even have surgery, you can be on methotrexate, as long as you're on this TNF inhibitor or whatever the new drug is, and your CDAI is less than 150, that's a success. But the definition that's not in use, and it's really the best definition, and the definition as a transplanter that I shoot for, is that there's no clinical disease, that is, you're in remission by CDAI, which the drug companies use, but in addition, there's no imaging, whether it's CT or MRI of the abdomen and pelvis of disease, there's no endoscopic evidence of disease, and there's no histologic evidence on endoscopic biopsy of disease. That, in fact, shows there's no disease, and which is not the remission used by drug companies. So if we looked at our results just out of Chicago, when we looked at time to relapse, that is restarting disease, restarting medications, and of course up here you're off all medications after the transplant, we could see we had a relapse that by 5 years, pretty much everybody relapsed, and in 3 years, 50% relapsed. So I considered that a failure. I considered my own trial disappointing. However, the gastroenterologist I worked with thought it was a success, because if you looked at CDAI as the definition, you can see for 5 years out it was always pretty much around 80%. And that's good because the drugs are about 40%, at best 60%, and they taper off at 2 years down to 40%. And there's not much published about the long-term continued remission on drugs, which slowly keep tapering off. And all the drug trials are done on people who are virgin to drug therapy, new onset disease, whereas in transplant we took people who had at least failed one TNF inhibitor. So it all depends how you look at it, but because this is a very intense therapy with a risk of mortality, I thought it wasn't yet good enough. Oops. And so we moved on a while, more than 5 years ago, 7 years ago, to allogeneic transplant for Crohn's disease. And why do allogeneic? Because my goal was, quote, cure, that is long-term, no medications after transplant, clinical remission, imaging remission, endoscopic and histologic remission. And of course, we took it right, this same group, before having extensive surgery, after having failed not just one, but at least 2 TNF inhibitors. In fact, they'd all failed at least 3 in some of the newer agents as well. And so I'll show you, we did here's the patients that we did transplant in, and as you can see, 3 of them had matched siblings, the others had no matched siblings, so we used matched cord blood units. And they were relatively young and mostly female, duration of disease. Despite their young age, they had disease for many, many years. They all had very complicated disease, which drug companies do not put in their trials. So drug companies do not take patients with stricturing or fistulae or prior surgeries. These patients obviously had that. They had a lot of perianal disease. Perianal disease in transplant are the ones that do the worst if you look at the data on stem cell transplant for Crohn's using autologous. And they had failed multiple therapies here. Even the first one had failed 3 different TNF inhibitors. And you can go on down where they've tried many different drugs, even thalidomide, and natalizumab is being used for this disease as well. So that these patients had failed multiple drugs and had surgery, strictures, and fistulae. They were definitely very sick patients that no drug company would enroll on a new trial. They failed everything. And if we look at the patients, what we did is our regimen was all patients got 200 milligrams of Cytoxan, but we dose escalated fludarabine and alemtuzumab to try to get engraftment because this was non-myeloablative and we wanted engraftment. Now, this is not listed in chronological order of dose escalation. It's listed by whether we had a sibling or cord blood for the transplant. And of course, with sibling, the allogeneic cell dose was very high because it was easy to get a high allogeneic cell dose. We didn't manipulate it. We didn't CD34 select or T cell deplete. But the alemtuzumab I felt would prevent GVHD. And if we looked for donor chimerism at 6 months, we had, for the T cells and the neutrophils, low level. By 5 years here, it was even lower. These 2 patients, again, we had donor chimerism at 6 months, and neither one of these patients would come back for follow-up. Our patients come from other states. They just would not come back, so they're alive, and we just have to talk to their referring physicians. These patients were really sick when we started. This one is the only one that is supposedly had some GVHD. It's limited, cutaneous GVHD, well controlled. None of our other patients ever got graft versus host disease. This one had short gut when we started due to extensive prior surgeries. We didn't want to do it. She still ends up with short gut, so still having a lot of problems from that and needing TPN from the short gut, despite what looks like a histologic remission. So you have to be careful in selection of patients, but they're alive and there's no GVHD here. These are the ones I want to focus on, our cord blood. Now, whether we did 2 units or 1 unit, we'd try to do 2 if we had 6 out of 6 matches for 2 units. At 6 months, we got no engraftment whatsoever. And if we did check later at 5 years, 4 years, this one at 1 year, there's still no engraftment. But what happened is our last patient, number 9, passed away at 3 months after transplant from disseminated adenovirus, which I felt was related to our conditioning regimen, so we stopped the study and just continued to follow all the patients. They're beyond 5 years now, so everybody's at least 5 years, and we've just followed them. And this patient had the highest dose of 150 fludarabine. Our lowest dose was 75, so we were doing dose escalation. And the highest alemtuzumab dose, 90. The lowest was 60, but actually one of these patients only got 30 of alemtuzumab because of an allergic reaction to it. So 75 and 30 would have been our lowest doses, combined with everybody got the same dose of Cytoxan. Despite dose escalation, nobody engrafted with cord blood. Nobody. Okay? Now, if we look at toxicity, what I want to take home to you is we had a large number of in-transplant toxicities. Grade 4 anorexia going on TPN, that really wasn't from our treatment. That was related to the disease. Same here and same here. These were all disease-related when they came to us. They were already on TPN, but we kind of just called it that because, just to be very clear. But in any event, they weren't really regimen-related, they're disease-related. But the grade 3s are clearly regimen-related, and what I want to show you is we had a high incidence of infections during transplant, Clostridium difficile. Here's Enterococcus in the blood, expanded beta-spectrum beta-lactamase producing E. coli. Enterococcus faecalis is mentioned. So the problem is that the GI barrier, the mucosal surface, is broken down, so these patients are very prone for bacteria in the gut and stool to leak into the blood once you drop their immune system, and you have to be very, very attentive to this. So, you know, you can transplant 200 MS patients and never get a positive blood culture. Here you can get it in just 4 of 9 patients going through transplant with Crohn's. Be very attentive to that, because of course you can handle it. Nobody got hypotensive, but you really have to be on top of it. The other is the alemtuzumab gave hives in a lot of them. It was very frustrating. I've never seen, we had used alemtuzumab at another time in other diseases, and I never saw this type of reaction. For some reason, these Crohn's patients very easily get hives to it. We figured out a way to prevent it. It'll be in our paper. It's using both antihistamines, blockers, H1, H2, and prostaglandins, and steroids. It's the only way to block it, and that's why one patient only got 1 dose of alemtuzumab. Long term, though, they did pretty well. Only 1 limited chronic GVHD. We can't confirm she won't come back. We've talked to her doctor. She's never biopsied. She thinks so. So we just call it that. We're not sure. 1 late C. diff. This one had actually renal failure history of it when she came to us from being on tacrolimus for this disease in the past. She went on, continued with renal failure, got a kidney transplant, short bowel syndrome, but her Crohn's is in remission. Here we had the late C. diff influenza. Here's a patient who had a pregnancy. Several years later, delivered a healthy, normal baby. Her Crohn's remains in remission. Fortunately, no long-term here. And then this one was the one that passed away, for which we decided just to stop the study. We did notify the FDA. They would allow us to continue. I voluntarily stopped it and just decided to follow the patients and see what happened, which is a good thing I did. If we look at CDA activity afterwards, it really goes to 0 in all of them. All the lines get mixed in here. That's why you don't see it. It's not just less than 150. It goes to 0. Importantly, we have limited time, so I can't go into too much detail, but after transplant, we did keep them on tacrolimus for 9 months to prevent graft versus host disease, and also graft versus host disease, also host versus graft disease to try to get engraftment. But after 9 months, we stopped all therapies, and they've been on no therapies for more than 5 years now. All of the valuable patients entered and maintained a clinical remission, imaging remission, endoscopic, and histologic remission for more than 5 years. That is, these are complete remissions. So if we look at 5 years, the clinical remission, CDAI, they're all in it. On no drugs now for 5 years. Well, for 9 months they were in tacrolimus and we stopped. No drugs. Imaging, which was MRI of the abdomen, there's no evidence of disease. Endoscopic, that which our GI physician did, and there's absolutely no evidence of disease. And then histologic biopsy, there's no evidence of disease. This is important because in our autologous transplants, when we did endoscopy, even if it looked good, when he biopsied, there were always lymphocytes, there was always subclinical evidence of disease, always, after the autologous transplant on the biopsy of the colon. Here, completely nothing. Now, when I say completely nothing, a few patients at 6 months and one took 2 years for it to be completely nothing. What they would show is Paneth cell hyperplasia. Paneth cell hyperplasia is supposed to be reactive regeneration of the gut mucosa and not evidence of disease, if you look in the literature. So there really was no evidence of disease right after the transplant with the first biopsy beginning at 6 months. But you can still see at 6 months and in one patient out to 2 years, Paneth cell hyperplasia. And then after that, suggesting it takes time for the regeneration in the GI tract. After that, there's absolutely nothing except one. Had a little mild because our gastroenterologist would do seemed like 100 biopsies everywhere. She just wouldn't stop. I think she didn't believe that there was no evidence of disease. But, there was a little mild terminal ileitis. That was probably just backwash ileitis. And the reason I say that is because the patient's now 7 years and still completely asymptomatic and refuses follow-up. One thing I found about Crohn's patients, they don't want to come back. It's very frustrating because you need that data. MS patients always want to come back. They want that MRI. They want to be reassured there's no disease activity there. Crohn's patients don't, especially if they're feeling good. And they definitely don't want endoscopy. So because it was so critical to get this data, we were actually, because our patients come from other states, would pay for their plane flight and their hotel to get the procedures done. So because we really wanted to capture this information. And obviously you can't afford to keep doing that. But allogeneic cord blood obtained clinical remissions, imaging, endoscopic biopsy remissions. There's no other way of defining a cure, and they did it for at least 5 years with no GVHD and no. The important issue also is we had no donor engraftment when we used cord blood, none, 0, which surprised me. That's why we were dose escalating. We were trying to get donor engraftment to make it work. We didn't need it. That was interesting. So the question is, why did it work without donor engraftment? either because this is a highly purged graft and we don't need the cells, or there's something in the cord blood that's very helpful, like mesenchymal stem cells that were just enough to push them over that the conditioning regimen by itself couldn't do. So my suggestion for the future would be to mobilize peripheral blood stem cells from the patient, which of course we never did because these were allogeneics, cryopreserve as a backup in case of a late viral infection. It's really collecting the lymphocytes more than the stem cells. It's that one patient died in adenovirus, and there's no effective treatment for adenovirus, and it's horrific to be at the bedside and see that. If we had backup patient lymphocytes to infuse, we would have gotten out of that mess. But in any event, the conditioning regimen I recommend, everybody got 200. This was our lowest dose of fludarabine. Or was it 70? I think it was 70. Was it 75? Yeah, it was 75. I should correct that. Alemtuzumab, our lowest dose was 30. So instead of 150, 75, 30, 200. Low dose tacrolimus for 9 months. Half would get infusion of 1 unit cord blood, half no stem cells. Again, these are non-myeloablative. They should engraft about the same time. It was day 12 to 14. And you just follow them for complete remission and see if the cord blood does anything at all. But this is the first treatment for Crohn's that has achieved these type of results. One-time treatment. And you have no evidence of disease beyond 5 years. So it can be done. It depends on the regimen and possibly the graft itself. So it's achievable, which is what is encouraging. All right, I was also asked to talk about systemic sclerosis, and there's 3 randomized trials that show the treatment that's being used currently is effective, and we just had the speaker before show the efficacy of this. The problem is, it's dangerous, so can we make it safer? That should be the key with systemic sclerosis. With Crohn's, I wanted to first show that we can really make this work. Done that now. In the future, maybe we need to clarify if the umbilical cord stem cells do anything. Perhaps it's a mesenchymal component because we have no way we had no flow measurement for that, and it may localize in the gut, so we can't find it. But certainly we don't have hematopoietic engraftment. Maybe it's just the regimen by itself. And then you could work in even making it safer. But here for systemic sclerosis, my focus was, we know it works, let's make it safer. And if you look at the randomized trials, you know, our first AHSCT publication in Lancet 2011 and our second 2013, and of course the publication by Professor Farge and Van Laar in the New England Journal. This was 2014 JAMA and 2018, the Sullivan publication. The problem is, and this was, you know, small number of patients. When we did a larger number of patients report, we had 6% mortality. JAMA was 10%, New England Journal 6%. The treatment-related mortality here is just too high, and that's, I think, the one thing that's still frightening rheumatologists from doing it, even though they know it works, is this high mortality. So if you look at the incidence of cancer, however, the regimens that don't have total body irradiation don't. The ones that did had a 9% incidence, and this mortality is probably now 10% because they did have a second case of MDS, which is TBI-induced, that hadn't died yet. Inevitably, that's a horrible radiation-induced MDS. It's horrible. You have no effective treatment except an allogeneic transplant, and that's often doesn't work. So this will probably hit 9 to 10% if there's more recent follow-up data. And if you look at disease-free survival, it's fairly similar. But the toxicities of the therapies are too high. If you look at our survival in our 90 patients that we did transplant in, here it is. And if you look at the European study, which was randomized, their survival, transplant's better control, but you had this early 10% mortality that has to be addressed. And so here's kind of a summary of the SCOT, which is the radiation, total body irradiation-based regimen of you know, Duke and Seattle versus the AHSCT from Chicago and AHSCT here from Europe, which was non-myeloablative, no radiation, Cytoxin, ATG, but 200 of Cytoxin. The Europeans used CD34 selection. We did not. I'm not sure you need to do that. It's more expensive, and I'm not sure it's better. But in any event, AHSCT and AHSCT the problem is cardiotoxic, and it's due to the cyclophosphamide. The SCOT increases the risk of malignancy, and it's due to the radiation. AHSCT and AHSCT and SCOT all improve the skin score. AHSCT and AHSCT, the cyclophosphamide-based regimens, improve lung function, and SCOT does not improve lung function. So those are the main differences. Now, where do we go from here? And that is, how do we improve safety? And so one of the ways to do it is there's a very good paper led by Dominic Farge as first author, saying these are the type of workup you have to do for these patients. It's very extensive: cardiac cath with fluid challenge, cardiac MRI, just to show that you can safely go through this. The problem with that is it excludes a lot of patients. The other problem is you as a transplanter need to go and sit and look at those cardiac MRIs yourself and know what to look for, that D sign, because a lot of radiologists don't know it and they don't look for it. In fact, I was the first to discover that when they were okaying these cardiac MRIs and a patient passed away with a normal cardiac cath, and I went and looked at it and said, look at this, I don't see this before. And they said, oh yeah, and so you have to look at it yourself. Unfortunately, in busy clinics, a lot of people don't do that. They just read the report, and the report isn't accurate. The other problems I had is we were turning away about a third of the patients, and they were getting angry. They still wanted the procedure. Well, you know, I let one talk me into doing it, and the patient died, and I decided after that I cannot be their friend. I have to be their doctor. I can't do it. But they'd still get very angry. They're between a rock and a hard place. They want to try anyway. They don't want to continue to live the way they are, and I understand that. But I couldn't take them to a procedure. I didn't think they would survive. So I finally decided to try a new regimen for, we called CAS, cardiac safe transplants, for the patients with bad hearts, only for people that we felt could not survive a cyclophosphamide regimen that we used or that the Europeans used here that should be excluded from transplant. That's the group we took to transplant. And basically the regimen is fludarabine based. So instead of cyclophosphamide based, it's fludarabine based, fludarabine, cyclophosphamide, ATG, plus or minus Rituxan, plus or minus IVIG. So everybody got this dose of fludarabine on these days, this dose of ATG. It's the same dose of ATG we used with our cyclophosphamide-based regimen. We only gave one dose of Cytoxan, so instead of 200, they only got 60. And when we first did it, we gave 500 of Rituxan day minus 6, 500 day plus 2, and then later we changed 500 here, and then IVIG on day 2 and 8. And we only took people with compromised hearts. That is, their pulmonary artery systolic pressure is greater than 40 without a fluid challenge, or greater than 45 with 1 liter normal saline infused over 10 minutes in the cath lab, or mean artery pulmonary pressure greater than 25 or greater than 30 with a fluid challenge, or a septal D sign, okay? So those were the group for this. The others went to our standard regimen. And what we found, if we looked at all patients, and the reason I'm separating this, anybody got rituximab, whether it was 2 doses or 1 dose with IVIG, did seem to do the same. So I don't have time to separate these two out. We're just going to compare those who got fludarabine, Cytoxan, ATG, and rituximab to those that did not get rituximab. Same dose fludarabine, Cytoxan, ATG, no rituximab. And there were 14 patients here, 14 in whether it was 1 dose of rituximab or 2, in each arm. So all 3, the different arms had 14, but these 2 did exactly the same. So there's 28 here, 14 here, 42 in total. Now remember, the New England Journal article by Seattle and Duke only had 33 transplants, so that's more than even in that article. And these were all the bad hearts, and of course diffuse limited with lung involvement. They had to be have lung involvement if they had limited disease, and of course they ended up with bad hearts. Their age, their sex, their skin scores were roughly the same, the mean on all of them. FVC, this was for all. Of course, this was without Rituxan with their TLC, DLCOs. For whatever reason, the group that didn't get Rituxan initially had a lower DLCO. It wasn't randomized. This was sequential change in the regimen. Oxygen dependent. You can see we took many people who were on oxygen. D sign, the majority had interventricular flattening. Pulmonary artery systolic pressure greater than 40 at rest or greater than 45 with fluids, and the same with mean artery pulmonary pressure at rest or with fluid challenge exceeding 30. So these were really sick patients with bad cardiovascular status. And if we looked at the change in the Rodman skin score after 1 year, you can see on the fludarabine, Cytoxan, ATG, it improved. It also improved if we added Rituxan, okay? It actually looks like it improved a little bit more here, but what happened is we had a high relapse rate here, and they got started on CellCept as well. So that's why they asterisk. These improved with nothing more. These improved, but many of them got restarted on CellCept. The FVC before and at 1 year, without Rituxan, it declined. With Rituxan, it improved. DLCO before and at 1 year, both slightly declined. But what we've shown in our prior papers, if the heart is compromised, the DLCO actually decreases after transplant. If the heart is not, it improves. So this is expected in the bad hearts. Now, if we looked at the immunoglobulins, IgG pre and at 1 year, so here's pre and at 1 year, between the two groups, with and without Rituxan, they're similar. But afterwards, I was very surprised. Whether you got Rituxan or not, the IgG is similar. Here's the IgA before transplant between the two groups and after 1 year later. So Rituxan didn't seem to diminish IgA or IgM. It actually seems a little higher here. It's not statistically different. So the rituximab, I was worried, would decrease your immunoglobulins, give more upper respiratory tract infections and bad lungs, but it didn't seem to do that, even if we'd given 2 doses with the regimen. However, here's the main difference. If there's no Rituxan in the regimen, we had 5 out of 14 relapses. If we had Rituxan in the regimen, 1 out of 28 relapsed in the first year. Deaths from disease progression in the first year, 2 of 14, and those were all relapsed. Here, none. And here, bacterial upper respiratory tract infections, surprisingly, if there's no Rituxan, we had more upper respiratory tract infections, 4 out of 14 versus 1 out of 28. The reason is that they were restarted on CellCept because the disease wasn't under control. Secondary autoimmune disease, hypothyroidism, rheumatoid arthritis occurred without Rituxan. With, it did not. So Rituxan prevented secondary autoimmune diseases, it prevented upper respiratory tract infections, and it prevented relapse. It was very beneficial. Now, if we look at other parameters between the 2 arms, they're the same and they're just good. For instance, the days of neutropenia, 4.4, 5.5. So we had 5 days of neutropenia. Normally, transplant with full dose Cytoxan, or if you use TBI and Cytoxan, you're neutropenic 10 days. We cut it in half. Less neutropenia is good. We cut the number of red blood cell transfusions markedly down, less than 2 per patient, about 1.7. We cut down the number of platelet transfusions to about 0.2. Most people didn't even get a platelet transfusion. And we cut the number of days of fever, number of people who had fever markedly down, and the number of days of fever markedly down. So this is a much, much safer procedure than full-dose Cytoxan or Cytoxan and TBI, than what was done in SCOT or what was done in AHSCT or ASSIST. It's really well tolerated. And when I used to take patients with scleroderma transplant, I was always worried because these could really be tough transplants. These became our easiest transplants. They became easier than Cytoxan ATG for MS. Really easy transplants. Caution, do a creatinine clearance on everybody. If the creatinine clearance is not at least 80, don't give them fludarabine. The major irreversible toxicity of fludarabine is renal failure with cerebellar dysfunction, so be sure you do that, okay? So if they've had renal crisis, bad kidneys, they're probably not going to be a candidate for this regimen. But if the creatinine checks out, this is a really great regimen. So CAST, 1 year results in everybody. Despite selecting the very high-risk patients that we would have excluded from ASSIST or ASSIST, results over the first year show neutropenia is only 5 days instead of 10 days. Transfusions per patient are minimal. Days of fever are minimal, less than 1. Majority never had a fever. Over 12 months, your FVC and your modified Rodman skin score improve. Relapse without rituximab is 66%. With rituximab, it's 4%. Secondary autoimmune diseases without rituximab, 21%. With rituximab, 0. Upper respiratory infections without rituximab, 28% versus 4% with. Again, when I first did this, thought this would have been reversed, more infections with rituximab than without, but this was related to rituximab preventing relapse and not going back on CellCept. And the immunoglobulins, surprisingly, I thought rituximab would have lowered our immunoglobulins a year later. They're the same, whether you got it or not. So, 3 medical societies, fortunately, including EULAR, have published positions papers stating that transplant is standard clinical care. Unfortunately, still a high-risk procedure. So the future of stem cell transplant is don't stay static. Alter, adapt, advance. The CAST regimen with rituximab, it's safer, it's cheaper. You can do it as an outpatient. It's so much easier. And if you're used to doing transplants for scleroderma, that's going to really surprise you. And you can do it regardless of cardiac function. If long-term results beyond 1 year hold up to what they did with these other regimens, it will be the new way of doing it. Thank you.